Thank you all for giving me the opportunity as well as for being here where sea, sand and surf is calling us much more than this room. So let's start. So whenever I was given this topic, that antimicrobial resistance, I remembered Lewis Carroll's that statement that you do all the running to stay in one place, because we know UTI is the most common infection that we deal in pre-transplant in our CKD population, diabetic CKD population, as well as post-transplant population. We overuse or underuse antibiotics and change antibiotics, look at different factors, but remain probably in the same spot instead of using. We have improved to some extent, again to be dragged in to evolution of some common organisms entering into the multi-drug resistant regime. So we do all the running and stay in the same place. So why and how we can address this? It has been very taxing that not only the UTIs in ICU have gone multi-drug resistant, but the UTIs that we see in the OPD, the post-transplant patient coming after 6 months, 1 year, is also showing an report of multi-drug resistance. So antibiotic use, which has saved us, that has also accelerated the physiologic process of resistance growing, AMR growing in gram-negative pathogens. We know UTI is maximally caused by gram-negative pathogens, are by nature, the gram-negative pathogens are specially adapted to improvise their virulence factors, to improvise their adaptability to come over the antibiotics killing domain. And they probably share some common mechanisms that we will be looking at. Let's first see some global data, some regional data to understand the magnitude and depth. And then we will come to the LMIC data, as well as we would look at what are the different types of UTIs that give us pain in tackling different populations. Are they different, and how we can address them? So see, the commonest organism in pre-transplant or usual UTI patients is the E. coli in 70% cases. In post-transplant population, E. coli is not the absolutely highest one. It covers around 40–50%, and other organisms which are not that prominent offender in the pre-transplant or the usual group, these also become an important etiology in post-transplant UTI. So probing deep into their multi-drug resistance pattern is important, and considering them as possible etiology when patient comes to us is important. And possibly keeping these things in mind, while I may neglect asymptomatic bacteriuria in general population, can wait for time to come with symptoms. When a post-transplant asymptomatic bacteriuria comes in 2 months and I see a rise in creatinine, I react. Somebody may tell me that why you react when rise of creatinine is there? Because time is very important window in that phase. And there are various important factors. We are high in immunosuppression. We have, the anatomy is not the perfect that could prevent UTI. And also there are multiple causes that can raise creatinine, but infection is one modifiable cause if I intervene early. So probably early 2 months asymptomatic bacteriuria, we transplant physicians react if the symptoms are present, or asymptomatic, which changes in pattern when it becomes late. We usually in non-transplanted population treat the uncomplicated urinary tract infection like cystitis with 3 to 5 days regime. Sometimes IDSA guideline tells us fosfomycin for a single dose. But same thing, when we give our post-transplant UTI population, for cystitis also, see the recommendations are of longer duration. The antimicrobial resistance grows here, knowing the duration of antibiotic use, whether we overuse or underuse. What are the justification if I say more than certain duration? And we need to evolve everywhere. We have a need to evolve this the microbial organisms which are region specific. Many times their resistance is also region specific. So this is a pattern where from you can find that how developing data is important. You can see this is the antimicrobial resistance pattern in one reported uncomplicated UTI series, and you can find the resistance is minimum in nitrofurantoin. So when you prescribe for uncomplicated UTI, the evidence tells you that you can use nitrofurantoin instead of trimethoprim sulfamethoxazole, which we have used earlier for many days. And this change had happened over time, and many changes might be in place in next 10 years when we have used nitrofurantoin quite frequently, and we may have to change our. So who are the players? Know your enemy. And among known AMR mechanisms, the plenitude of different beta-lactamases. Beta-lactamases are not one or two. They are many, and they are most prominent offenders to develop antimicrobial resistance. And different populations, patient populations may develop AMR in UTIs in different way. The major factors is history of antibiotic consumption and the physiology of urinary flow. If your urinary flow is slow, if you have a congestion there, you might get more chance of developing antimicrobial resistance there. The bed of infection, not only the urinary tract. Probably Dr. Kalra was talking about the crosstalk of the gut and the vaginal tract. The gut microbiome and the vaginal tract microbiome, we are going to alter with the antibiotic therapy. And that healthy, good microbiome is being lost and replaced by something which is not a happy coexister with us. So probably that is also very important to take into account, that when we can use in milder infections, if we can use non-antibiotic, if we can promote the preventive and primordial prevention measures, that would be more helpful. So pharmacokinetic properties and the physicochemical composition of the urine is also important, as Dr. Kalra was highlighting in his first talk, that pH of the vaginal pH, the urinary pH, and their proneness to infection changing with the time. And so this is extended spectrum beta-lactamase producing ESBL-E and CRE infection in solid organ transplantation. This was a cohort which reported almost globally, that this cohort is known as increment sort cohort, and this reported the infectious complications globally. So what did they say? That stratifying the transplant type, KT patients did have the ESBL-E producing infection maximum, and many of them went into the urosepsis domain to cost the life as well. They have highlighted the bacterias, beta-lactamases, which have become important in causing AMR, and Also, the post-transplant bloodstream infection that is most commonly caused by UTI. That also highlights why we should be exploring the situations that cause AMR and address AMR. That leads to who initiated steps that Saurabh was discussing to prevent the AMR, prevention of antimicrobial resistance development. This is a small data. When I was looking for that, whether I am stressing on regional data collection, it needs a dialogue between the nephrology department, transplant nephrology, and the microbiology only for comparison of a K2 infection, general nephrology infection, and other common population infection, which can highlight that what are the important need, prioritizing the genetic studies to address the virulence of the organism, or prioritizing the other important factor that comes, that the antibiotic overuse, underuse, and following a goal-directed policy, which may be different in different institute. All the prominent institutional heads are here. I think so most of the prominent institutional heads, I'm finding Narayan here, and excellent microbiology department in SGPGI, who can give me this, give us this, enrich us with this regional reports. This is done in common population, but I didn't find a comparable report anywhere. It told about the general population UTI, but similar we can have. So microbial, I was thinking that we'd see a lot of CKDs also, whether the transplant population I see when I'm looking at the antimicrobial resistance in transplant population, whether CKD population is same at risk. See, the CKD and non-CKD population, they do not differ much in having the organisms causing infection. Further, when looking at the risk factors that can cause the infection, when univariate analysis they were doing, they were finding age, obstructive, both upper lower tract obstruction, and catheter-associated infections, and many other things are coming up. But when they were doing the multivariate, then many things that went off and remained the catheter-associated infection. So this catheter-associated area probably is the area where we need to look at that how antimicrobial resistance develops, and that is affecting our population. And this I can translate to the post-transplant population as well, as they will be having the indwelling catheter for time, and limiting the indwelling catheter in the post-transplant patient becomes an urgent necessity for a dialogue in the multidisciplinary surgical team. So these things I think important also, why we are looking at these risk factors. All these risk factors taken together can be incorporated into many score development. Many ICUs have done such scoring, that how they will develop their antibiotic stewardship. Having AI as an analytic tool, which is excellent and can do miraculous jobs in this matter, in this clinical factor enumeration, and then applying them to a validation model in a validation cohort, and then coming out with a score which can grade the infections, grade the illnesses in the ITU, and can tell them that who are the patients in whom we will start with broad spectrum antibiotics first, and whom we should continue with perseverance with narrow spectrum antibiotics for little longer duration. So all these things that can be done. After that, coming to the genetic issues, that the beta-lactamase production, how there are more or less 4 major things, that the beta-lactamase production, I told that multiple beta-lactamase production has been there, then the DNA gyrase, then the porine development, which will allow not the antibiotics not to enter in the microorganism. Then the other mechanism is the efflux, which will drive them out before they become really effective. And combination of all these things are not uncommon. Having lab for looking into this and developing newer antibiotics still now is growing in Western world. We need to have similar things in our hospitals, at least the major teaching hospitals also, so that we can collect the strains and can put them, subject them for such analysis. We should remember that whatever the lab excellence tells us, the clinical part combination will ever remain important thing. At the organ level, at the compartmental level, there are various issues which can be responsible and should be addressed, should be addressed while we are looking at the antibiotic choice and antibiotic duration for the patients. As we have already discussed, that there may be organ level obstructions and rise of pressure which can increase the chance of infection there, and infection, recurrent infection with the asking for overuse of antibiotics. There in the compartment level also there are various issues about the physicochemical character of the urine, which may promote infection, and recurrent infection and antibiotic use again will invite the virulence of the organism, and after that will remain the microbiomes of the gut, the vaginal tract, and many other issues which we should remember as always interfering. I think this chart has been shown multiple times by more than one speaker, so I'm not going into detail, and I have already highlighted that the specific risk population, each population has their own risk factors, and transplant population definitely have many risk factors. A statewide quality initiative has been initiated in an UK hospital to address the asymptomatic bacteriuria, and you can see the decreasing antibiotic use has helped them a lot. There has been detailed discussion about asymptomatic bacteriuria. So some studies said, yes, treating asymptomatic bacteria in transplant population helpful. Some remain non-committal, some said harm, as had been already shown by our second speaker in detail. So I'm not going into detail of it, but telling that first 2 months, usually we transplant physicians, we treat asymptomatic bacteriuria. When late asymptomatic bacteriurias, we don't treat. So there had been an universal practice recommendation by our expert opinion group, in which our major teaching institutions had taken part to formulate that guidance. I should request everybody to go through that and follow the recommendations that had been published in Transplantation. Universal practice recommendations, expert opinion had been written there, and this part was, main author was Dr. Shishir Gang, and was contributed by Dr. Narayan Prasad, Dr. Sam Banchal, and Dr. Camilla Cotton was co-author in all, the co-author and editor for the whole book. So these guidelines should be followed to develop a baseline antibiotic use, overuse, and underuse prevention. So with these guidelines, I would ask everybody to develop communication between each other so that each one can feel that where they are, they feel like deviating from this protocol, and why they feel like deviating from this protocol, develop data of own, and then come up with new recommendations which can be tested evidence-based. So this is again a picture which shows that I have shown this previously. It's not moving. Oh, I'll follow this one. So strategies to make your armamentarium score, looking at the clinical score model, combining antibiotics rather than monotherapy for ESBL-E and CRE. Saurabh was talking about it. Newer antibiotics, ceftazidime, avibactam, and meropenem, valobactam have come. Like them, many other are under experimental model, revisiting the older where we can use them, and ultimately looking at the non-antibiotic alternatives. These are the AMP, some peptides which are found in the environment. These peptides may have the potential of altering our immunological milieu as well as to kill some bacteria by the unique mechanism. I would request the newer generation to go through this and discuss and think about the probability of using these things. Thank you for your patient hearing. I'm ready to take